Hi everyone, my name is Jacqueline McKay, and today I'll be speaking on excoriation disorder, also known as skin picking disorder. Excoriation disorder is not triggered by obsessions or preoccupations. However, they may be preceded or accompanied by various emotional states such as feelings of anxiety or boredom. They may also be preceded by an increasing sense of tension or may lead to gratification, pleasure, or a sense of relief when the skin is picked. Individuals with this disorder may have varying degrees of conscious awareness of the behavior while engaging in it, with some individuals displaying more focused attention on the behavior and other individuals displaying more automatic behavior. The DSM lists 5 diagnostic criteria for excoriation disorder. 1. Recurrent skin picking resulting in skin lesions. The most commonly picked sites are the face, arms, and hands, but many individuals pick from multiple body sites. Individuals may pick at healthy skin, at minor skin irregularities, at lesions, such as pimples or calluses, or at scabs from previous picking. Most individuals pick with their fingernails, although many use tweezers, pins, and/or other objects. In addition to skin picking, there may be skin rubbing, squeezing, lancing, and biting. Individuals with excoriation disorder often spend significant amounts of time on their picking behavior, sometimes several hours per day, and such skin picking may endure for months or years. Individuals with skin picking disorder tend to have lesions which they cover up with makeup or clothing. The second diagnostic criteria from the DSM is repeated attempts to decrease or stop skin picking. The third diagnostic criteria is the skin picking causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The fourth, the skin picking is not attributed to the physiological effects of a substance or another medical condition. And the last, that the skin picking is not better explained by symptoms of another mental disorder. Some of the diagnostic features of excoriation disorder include recurrent picking at one's own skin. They may also be displayed as skin rubbing, squeezing, lancing, and biting. The effects of skin picking may result in infections and scars, which can cause embarrassment and social isolation by the patient. Patient may develop a ritual involving skin or scabs. Skin picking can also be accompanied or preceded with various emotional states. Some patients report picking in response to a minor skin irregularity or to relieve an uncomfortable bodily sensation. Pain is not routinely reported in association to skin picking. Some skin picking is done in a more focused manner, while others engage in automatic picking. Skin picking is not normally done in presence of others except immediate family members, and some individuals report picking skin of others. So far, there is no clear neurobiological explanation for the development of this disorder. However, there have been many studies done recently to help explain more. In 2013, a study by Grant and others used neuroimaging on the brains of those who suffered from excoriation disorder. They found bilateral abnormalities in the anterior cingulate cortex on the left tempoparietal junction, which has shown to suppress motor responses. Recent research examining neurocognition in excoriation disorder has shown deficits in motor inhibition, which appears to be correlated with frontal cortex abnormalities. One study by Oddlog and others found impaired inhibitory control in excoriation disorder subjects compared with healthy controls. Additionally, in a study done by Adams in 2012, they found that the severity of excoriation disorder may be associated with higher levels of impulsivity. The clinical relevance of impaired motor control to excoriation disorder remains unclear. Because previous studies implicate impairment in inhibitory control in repetitive picking behavior, it can be hypothesized that impaired inhibition would be associated with the severity of excoriation disorder. The lifetime prevalence for excoriation in adults is 1.4% or a little bit higher. 3/4 or more of individuals with the disorder are female. Most often, onset of displaying symptoms is during adolescence, commonly coinciding with puberty. It frequently begins with acne, but the sites of skin picking may vary over time. Usually skin picking is chronic, with waxing and waning if untreated. For others, skin picking may come and go for weeks, months, or years at a time. Most admit to skin picking, thus dermatopathological diagnosis is rarely required. Disorder may have characteristics of histopathology. Excoriation disorder can be associated with distress, including social and occupational impairment. Diagnosed patients often spend 1 hour or more a day picking, thinking about skin picking, as well as resisting urges to pick. Patients often report avoiding social or public events and also report experiencing work interference from skin picking on at least a daily or weekly basis. Students with the disorder often miss school and experience difficulties studying or managing their responsibilities. Medical complications include scarring, tissue damage, and infection, and rarely synovitis of the wrist. There are a few scales developed to help assess the severity of excoriation disorder. In 2001, Kuethen, Wilhelm, Deckersbach, Engelhard, Forker, Baer, and Janicki developed the skin picking scale. This scale is a 6-item self-reported questionnaire that measures the severity of skin picking behaviors. Scale items consist of the following categories: frequency of urges to pick skin, intensity of skin picking urges, time spent picking, interference due to skin picking, distress, and avoidance. Items on the SPS are rated on the 5-point scale, 0 being none and 4 being extremely, with a total SPS score ranging from 0 to 24. A cutoff score of 7 distinguishes self-injurious skin pickers from non-injurious skin pickers. Higher total SPS scores are indicative of more severe skin picking behaviors. In 2012, this scale was revised by Snorrison, Olafson, Flessner, Kuethen, Franklin, and Woods. In this revised version, the authors aim to reduce the ambiguity of the language in one of the scale items by replacing the word distressed with the phrase emotional distress. 2 additional items assessing control over skin picking behaviors and the physical damage to the skin as a result of the picking were also added, making the SPSR an 8-item self-reported measurement that is more congruent with the diagnostic criteria of the DSM-5. Items on the SPSR are rated on the 5-point scale, 0 being none, 4 being extremely, producing a total score ranging from 0 to 32 as opposed to the original of 0 to 24. Exploratory and confirmatory factor analyses were conducted, revealing 2 factors: a symptom severity subscale and an impairment subscale. Also in 2001, the Skin Picking Impact Scale was developed by Kuethen, Deckersbach, Wilhelm, Engelhard, Forker, O'Sullivan, Janicki, and Baer. The SPIS is a 10-item self-report questionnaire that is used to evaluate the psychosocial consequences that have occurred from repetitive skin picking. Scale items on the SPIS assess for avoidance behaviors, time spent concealing lesions and/or scars, social and relational challenges, and feelings of embarrassment and unattractiveness from picking one's skin. Items are rated on a 6-point scale ranging from none being 0 to severe being 5, resulting in a total SPIS score ranging from 0 to 50. A cutoff score of 7 distinguishes self-injurious skin pickers from non-self-injurious skin pickers. In 2009, the Milwaukee Inventory for the Dimensions of Adult Skin Picking, also known as MIDAS, was developed by Walther, Flessner, Connolly, and Woods. MIDAS is a 12-item self-reported assessment tool that was developed to characterize and assess two different types of skin picking. One being automatic, which is also known as unconscious, unintentional picking, and two being focused, which is also known as conscious and purposeful picking. Results obtained from an exploratory factor analysis reveal two factors, each containing 6 items. Factor 1 consists of questions assessing if an individual is predominantly a focused skin picker, such as, I pick my skin when I'm anxious or upset, while Factor 2 comprises questions assessing if the individual is an automatic skin picker. Such an example, I am usually not aware of picking my skin during a picking episode. Items are rated on a scale from 1, not true of any of my skin picking, to 5, true for all my skin picking, with scores ranging between 6 and 30. The authors state that the MIDAS is not intended to produce a total score and that each subscale should be calculated separately. Excoriation disorder is often accompanied by other mental disorders such as obsessive-compulsive disorder, trichotillomania, major depressive disorder, and most recently borderline personality disorder. I found an interesting case which showed a relation of excoriation disorder and borderline personality disorder that was displayed in a form of ritualistic self-harm, one of the common symptoms of borderline personality disorder. An additional diagnosis of another specified disorder may be called for if other repetitive body-focused symptoms are displayed. The symptoms of excoriation disorder can be found in other diagnoses. For instance, psychotic disorder, skin picking may occur in response to a delusion or a tactile hallucination. Other obsessive-compulsive and related disorders, for example, those who pick their skin solely because of appearance concerns should not be diagnosed with excoriation disorder. Neurodevelopmental disorders. While stereotypic movement disorder may be characterized by repetitive self-injurious behavior, onset is in early developmental period. Somatic symptom and related disorders. Excoriation disorder is not diagnosed if the skin lesion is primarily attributable to deceptive behaviors and fictitious disorder. Other disorders. Excoriation disorder is not diagnosed if the skin picking is primarily attributable to the intention to harm oneself that is characteristic of non-suicidal self-injury. In regards to other medical conditions, excoriation disorder is not diagnosed if the skin picking is primarily attributable to another medical condition, such as scabies or eczema. And last but not least, excoriation disorder should not be diagnosed with substance and/or medication-induced disorders, such as cocaine and meth. Treatment for excoriation disorder is really twofold. You have the physical aspect and then you have the mental aspect that also needs to be treated. For the physical aspect, excoriation frequently requires antibiotic treatment for infection. Sometimes surgery may be required to help reduce the scarring that the lesions of skin picking has caused. From the mental point of view, current first-line treatment for excoriation disorder depends on the underlying psychiatric issue. The mainstays of treatment are selective serotonin reuptake inhibitors, or SSRIs, as they can reduce obsessive and depressive symptoms. Benzodiazepines have also been prescribed to reduce anxiety. An antidepressant such as doxepin has also been prescribed, and a mood stabilizer such as lithium. Cognitive behavioral therapy for excoriation disorder might include insight-oriented therapy and requires a strong doctor-patient relationship, similar to the treatment of other obsessive-compulsive related disorders. Here are the citations that I used for this presentation. Thank you for listening to me ramble, and I look forward to our discussion.